Well, the test is moving right along now, and this test goes quickly. You'll find that it's almost 3 hours long by the time you line up, take the test, and line up afterwards, and it'll go a mile a minute. It's well prepared, but you will keep it moving. Now, Madeline Medella is our station 13, and she's a 53-year-old with left foot pain. Now, she points to the bottom of her foot. Will probably be, patient instructions, but I try to give you at least a little idea where we're going. Write down these orthos so that you know and think in your mind where you're headed, what kind of questions might be appropriate in this room, what kind of data, kind of be thinking about the location and area of the body. Do you want to ask about if it's one or both feet? Those kinds of things I want you taken into stock. Then move into that next station, try to answer those questions, and we'll talk on the other side. Well, we didn't glean much information from this patient, so I think I would have had a chat with her about her foot pain. It looks like it's isolated to one foot. The anterior and posterior draws, where we're drawing and pushing on the ankle, give us nothing. But when we did active and passive range of motion, and they don't have to say active and passive range of motion, they could have said O'Donoghue's range of motion, they could have just said voluntary range of motion, which is she does it actively, or they could have just said range of motion, which means active and passive. But dorsiflexion, when she dorsiflex, it really hurts the bottom of her foot. So, I wonder why. Is it localized? Can she point to the side? She points right to the heel if you asked her. But if you don't ask her, you don't get that piece of information. When you squeeze it, not so much. Tennell's test at the ankle. Now remember, that would be medial that we're tapping on for the posterior tibial nerve. And then Thomas or Simmons, they asked you to verbalize, and that's when you turn the patient over, squeeze this to see if the foot's moving for an Achilles rupture. And she, of course, doesn't have an Achilles rupture. All right, we go into the next room, and there is a bit of help. We're seeing an extra os up here, the os trigonum. We're seeing a heel spur. It's been onset for about 3 months. We haven't asked her what she does for a living, but I think they told us... No, they didn't tell us what she did for a living, but she's 43. A lot of things could be happening. So maybe she walks around, maybe she's a nurse, maybe she's a housewife, but at any rate, maybe she's wearing high heels and she's developing this heel spur, which goes along with plantar fasciitis, which would cause this kind of problem. So if I'm looking at answers, I like heel spur. I love plantar fasciitis. I like aponeurosis of the plantar. We got anything like that? Sesamoiditis. That's when you have a lot of sesamoid bones and they hurt, but we don't have a picture of multiple sesamoid bones. Carpal tunnel, no, that would be radiating burning pain. Deltoid ligament instability, no, when we did all the draw tests, everything was fine. Morton's neuroma would be burning pain. Achilles rupture was ruled out by the Thomas test. Calcaneal fracture, the x-ray would rule out. How about a degenerative heel pad from walking on it? We thicken the heel pad, it'll get real thick with acromegaly, but with this kind of behavior, it'll get thin. So it thins naturally with age, so that sounds like at least a pretty responsible piece of information. And there's our plantar fasciitis, yay! Okay, so we're going to pick that plantar fasciitis, we're going to pick the degenerated heel pad, and we're going to pick the heel spur. So that's 1, 8, and 10. With number 1 being obvious, the 10 is the knowledge-based question, and 8 is understanding what happens with aging. Then it says, hey, what's your case management? Finally, they don't say initial case management. So all in all, what do we want to tell this lady to do when she's got a heel spur like that? Well, one of the things I'd like to tell her is to get out of her high heel shoes. I'd like her to stretch that calf muscle back here, all these Achilles, so that Achilles tendon is getting stretched. So what do we got here? So, increased running regime sounds a little silly. Refer to an orthopedist, not necessary. A walking cast is not necessary. Trigger point. Let's kind of beat up all the trigger points along the plantar fascial surface. I'd love to adjust that foot because it's probably rigid. Keep off feet for 3 weeks. No, we want to keep things moving. So trigger point sounds good. Heel cushion shoes with arch support. Heel cushions, they can make a little cushion that has a little hole in it to help her because that's probably going to hurt bad. That sounds like a plausible idea. Rigid, no, we want non-rigid shoes. Remove arch supports, no, we want her to have the support. Heel lift, no, we don't want any more heel lifts, we want a sole lift. Stretch the plantar fascia, yes, we want to stretch the plantar fascia because she's not using her arch, and we'd like to stretch the gastrocs and soleus. So that answer is not there. So don't forget that. So stretching the muscles, okay, is very important. Okay, we want to get her into what we call a heel cushion or a donut cushion in her shoe with her supports, and we want to, where was it?
Number 4.
Number 4, there it is, trigger points on the plantar fascia. It's going to beat it up a little bit, so we might even ice it afterwards if that was available as an answer. Okay, station 15 already. So remember, 90 seconds to talk about Ms. Lamott, this 30-year-old that has left hand pain, and here are the things that you're asked to do. Remember, let's try to think about what kinds of questions, because the additional information that I kind of put on this is usually only available in this room. So see if you can think about some good questions to ask her, and we'll see you after you've answered. All right, we've entered this room, and she's got some left hand pain. Is it both hands or just your left hand? That's the only one that ever bothers you. How do you describe this pain? Is it throb? Is it burn, tingle? It burns. Okay, so I would have asked a few questions like that, gotten busy right away, had her put both hands out. Remember, I have her make a fist, I squeeze one, release, squeeze it again, release. So we do Allen's test, and we would do that bilaterally. And of course, no one can fake an abnormal there, so that would be normal. Phalans and reverse phalans, easy enough to do. And she says, yep, they barked, it's the 4th and 5th digits. So we already should be thinking ulnar nerve at this point. Tinel's test, tap, 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 they said was normal, which means it's not the median nerve. Remember, elbow is for ulnar. Elbow is for ulnar, wrist is for the median nerve. So I would expect Tinel's at the wrist to be normal. Froment's test is where we put the paper in and we pull it out. And she is probably perfectly fine with that because that's a median nerve test. Froment's, what's the matter, Dr. Laura?
It says it's positive. She was weak on that with her 4th and 5th digits, I guess, when they put it through. I guess they did a different area.
Oh, that's Froment's. Some schools actually do it at each one of the sites.
Yeah.
So I guess if you bothered to do this site, it would be okay if you only did this site, but you would not get this piece of information. So if you are a school that takes the time to do all of these, she was taught to have weakness here. It's probably not extra points, but it was extra pieces of information. So thank you, Dr. Laura, for pointing that out. It threw me for a minute. Then C8 and T1 dermatomes, and the results are normal, so what they're trying to rule out is radiculopathy. Now remember, on these dermatomes, we have to tell the patient to shut their eyes. Remember, they're comparing from side to side. Now you need to open your eyes. And then by this time, there should be about a minute left in this room. You should be asking more questions about the quality of this pain. If it's only one side, what did they mechanically do with their hand? Was there any kind of trauma, repetitive things that they do? So that would have been how you were kind of ending up in that room.
Also on number 4, you were going to verbalize how to confirm a positive finding that you found perhaps on Froment's test, and that would be with the nerve conduction velocity, and EMG would have been the answers to confirm the positive finding.
If that's what they wanted, another way to actually talk about Froment's is to see if they roll their thumb around. So I'm not sure if they meant on the Froment's action test or if they really meant how to confirm this for court. So that's kind of an unclear question. So read it very carefully and kind of watch for your examiner to do this. If they immediately check off, then you've hit the bullseye. Now, as we go to station 16, the follow-up station, she says pins and needle sensation. Finkelstein's test is negative. So they probably wouldn't have given you the pins and needles. They probably would have given pins and needles are burning up there. What I think they're trying to do is kind of give away very little information about the ulnar nerve so that you have to come up with it. You'd get normal pictures here of the hand, because we're not going to see anything in the hand with potential peripheral nerve entrapment. So at this point, I hope you're figuring out it's ulnar nerve, peripheral nerve entrapment. So how do I find those answers? Well, peripheral nerve entrapment's a ding-ding. That one should almost jump off the page at you. Tunnel of Guyon is where the ulnar nerve is trapped. So those two are golden. Number 1 and number 10. Radiculopathy's out. RA is out. That would be bilateral. Ulnar nerve, there it is, ulnar nerve. So number 1, number 4, and number 10. But avascular necrosis, that would be post-trauma. Median nerve entrapment, we ruled out median nerve, remember? Radial nerve entrapment would be the back of the hand. Carpal dislocations, we need some kind of trauma. And carpal tunnel would be median nerve. So our ulnar nerve entrapment is tunnel Guyon, ulnar nerve entrapment, and peripheral nerve entrapment. Neuropathies. So now, complications to this case. we expect, remember the location that it lives in, we expect this area to lose, its ability. So claw hand, the hypothenar atrophy. So we've got hypothenar atrophy. Paresthesia of 3, 4, and 5 is close. I wish it said just 4 and 5. Let's see, drop hand. Drop hand is all about the radial nerve, so it can't be that. Thenar atrophy is median. Apand is median. Claw. Claw is ulnar. So we've got hypothenar and claw I love. Glove anesthesia would be all of them. Spread to 1, 2, and 3 digits it will not do. Swan neck it will not do. Cock-up split it won't do. Okay, so even though I don't like this third digit in here, not every dermatome chart, not everybody's made the same, not every pure patch is the same. So we're going to say hypothenar atrophy number 1, paresthesia 3, 4, and 5 number 2, and claw hand number 6. And those will be our best answers out of what's available. All right, Mr. Tubbs is a 32-year-old male with right chest pain. Now you're going to have a thoracic station. You may have 2 of them. So this is where they could throw in those dermatomes. Remember, make sure that you read whether they're anterior or they're posterior. Whether it's T1 through T8 or T1 through T12, or they just say thoracics, which means all of them on the posterior, or whatever it is that they're requesting. Did they want you to do percussion, which is with the reflex hammer? Did they want the tuning fork done? Okay, so what do they want? Scheppelman's, tuning fork test on the ribs, sternal compression, Soto Hall, and rib compression. So while you're in there taking care of Mr. Tubbs, ask a few decent questions. Think about what would be some key questions as you do this and get the positives. Alright, so let's find out about this right chest pain. So we do Scheppelman's and we're having him do this and he says it hurts and it hurts both directions. And if we really find out where, remember the chest is this entire thing. So he doesn't say it's on the front, which some of you might have inferred. It's on the back here, okay? So it's on the right posterior. And when we do the tuning fork test, which tuning fork did you pick up? Your 128 or your 256? You picked up the 128. And when you vibrated, you found that it hurt from 8 to 10 ribs and stayed pretty local, I'm thinking. Or it could have radiated. So maybe the patient would say kind of a little bit of each to give you some diphthys. So who knows? Sternal compression is where we actually place the patient's hands here and push like this, as opposed to rib compression would be to push on both sides of the anatomy. That seemed to maybe cause a little more pain in the given area. Soto Hall test would also cause some pain in the given area, but not a positive Soto Halls, really. So it would be, really I should have said negative, but positive. Soto Hall is kind of a gee, something's wrong, so depending on how hard you stress, you could have stressed the area of involvement. So it's a generalized test. And then the rib compression test is what I just said. You push in on both sides. So this would not have taken very long. This room is fast, which meant there was time to ask questions. Does it radiate? Is it local? Be sure and do that in the future when they give you these opportunities. He played soccer and fell on his rib about 3 weeks ago. Okay, and fixation at T4 to T6. So they're almost telling you that there's rib subluxated and there's possible rib fractures. So if you go down here, that's actually what we did pick. We decided to go with intercostal neuritis is a possibility, and so is your rib fractures, and so is your thoracic subluxation. Probably the 2 big things are 6 and 8. If you got 6 and 8, you are doing well, because number 3 really could have been quite a few things. I like the fact that, it's not on the front, so you can't go TCs or costochondritis, and costochondral calcification would have to show up here. So really, intercostal neuritis just becomes the diphthi of choice, just by, it's the 3rd best piece of crap. You know what I mean by that? It's not a good answer. But take a look now at care and the management, because I think this got a little bit more complicated because it's 3 weeks old and they're asking initial. So you have to know that initial means from the point that we're at. So the initial treatment, as this case comes in 3 weeks old with callus formation, the ribs are healing fine. So that means then probably some DP is going to help facilitate more healing. That we're going to not need emergency care, but we're probably going to want, I know there's a good answer up here somewhere. We went DP, decrease athletic activities till they're all healed. So I like that, just decreasing activities in general, I would have picked it. So 2 and 3 we like, and then it becomes a real problem between 9 and 10. Well, do I want to do soft tissue? Yeah, soft tissue, but not for trigger points. He doesn't have trigger points. So low force thoracic adjusting, about 4 to 6 weeks. Yes, we're just at that borderline of I don't like it, but it's the best piece of crap left, because he really doesn't need to stay in bed. He doesn't need ER. He doesn't need antibiotics. You know, we can't do ice and heat. We've decided deep heat's going to get the blood supply rocking and rolling, and the lumbar is definitely out. So I think by default we love picking 2 and 3, and we'll pick 10 if we have to pick something.